Welcome back to the deep dive. Today we're cutting through some of the noise. We're going to unpack a hormone that's often misunderstood, maybe even a bit controversial, but, well, it's incredibly important for overall health. Estradiol. Using your sources, our mission is really to give you a thorough, evidence-based look, everything from its surprising benefits to, common myths and how it's actually used. The goal is for you to be truly well-informed.
Absolutely. And what's fascinating really is just how much misinformation or maybe misinterpretation is out there about estradiol. Our sources, they really show a significant gap between the actual scientific literature and what's often common medical practice. So this deep dive is pretty essential, I think, for you to grasp the true impact of this hormone.
That's a really powerful point. Okay, so let's start with the basics. What exactly is estradiol?
Well, at its core, estradiol is a primary estrogen. It's a fundamental sex hormone. It's often produced in the body through a process called aromatization. That's basically a conversion, mostly from testosterone. And importantly, it's present and plays a really crucial role in both men and women.
Right, in both.
Yes.
Yeah.
And understanding that role is key to debunking a major misconception. Like, right off the bat, estradiol often gets blamed for things like visceral fat, the fat around your internal organs. But the sources we looked at clearly show estradiol is more like an innocent bystander there.
An innocent bystander? How so?
Well, it doesn't cause visceral fat. It's actually produced by it, in part.
Yeah.
And get this, studies actually show that when you give estradiol, especially with testosterone, it reduces visceral fat. It doesn't increase.
Reduces it. Okay, wow.
Exactly. And blocking estradiol, that's been shown to increase visceral fat. So the complete opposite of what many people think. What's really fascinating is, well, understanding this relationship with visceral fat and also insulin resistance. It's foundational to grasping all the broader health benefits. It can significantly improve insulin resistance too. Some studies even suggest higher doses work better with a no plateau effect.
No plateau, meaning the benefits just keep increasing with the dose.
That seems to be the indication, yeah. Unlike some other treatments where effects level off.
That's a huge revelation for many people, I bet. But hormones are often seen kind of narrowly. Does estradiol's influence stop there? Or, do our sources point to wider benefits, unexpected ones, maybe?
Oh, the scope is really extensive based on these sources. Let's walk through some key areas. First, and then this is a big one, cardiovascular protection. Imagine cutting your risk of heart disease and overall death by almost half. That's what several major studies, Finnish, the Estrogen Alone part of the Women's Health Initiative, WHI, Nurses Health Study, the core study they all consistently show. We're talking a 40–50% reduction in coronary heart disease events and total mortality for women.
40 to 50%, that's incredible.
It is. And this protection is strongest when estradiol is started early in menopause, usually ages 50 to 60. It seems to prevent new plaque from forming and can even stabilize plaque that's already there. But, and this is really crucial, the timing matters. If treatment is delayed.
Delayed how?
Like starting in women age 63 or older. There, studies showed an initial increased risk of plaque rupture, about 30 out of 10,000 women in the first year. A paradoxical harm. Though interestingly, protection seemed to follow after that initial window. So timing is absolutely key.
So starting early is critical for women for that heart benefit. What's the mechanism? How does it work?
Mechanistically, estradiol boosts nitric oxide release. This improves endothelial function, helps blood vessels relax, and widen better blood flow, basically.
Okay, makes sense.
And it also has good effects on blood lipids. Plus, it reduces some key markers of heart stress and inflammation, like cardiac troponin 1, immune complexes, complement activation, all things linked to plaque. Now, for men, it's interesting too. Raising estradiol levels, often by giving testosterone, which then converts, well, that's been linked to better lipid levels. And also a significant reduction, about 30% lower risk for a doubling of concentration in prostate cancer risk, at least in observational studies.
Lower prostate cancer risk, wow.
Yeah, whereas blocking estradiol with AI therapy, that's linked to harm. Worse lipids, higher cardiovascular risk.
It really sounds like a powerhouse for the heart, for both sexes.
Right.
What about bone health? That comes up a lot with hormones.
Absolutely. Estradiol is important there too. It plays a role in getting to peak bone mass, not just for young women, but for young men and older men as well. Low estradiol levels, directly linked to bone loss. For older men specifically, when bioavailable estradiol drops below about 40 pmol, or roughly 10 pgml, that's seen as a major cause of bone loss.
That's a pretty clear link. And metabolically, you mentioned insulin resistance. How does it affect metabolic health and dyslipidemia, unhealthy cholesterol levels?
Right, and here, how you take it makes a difference. Oral estradiol seems particularly good at improving dyslipidemia. It lowers LDL, the bad cholesterol, quite significantly, and it increases the good stuff like HDL lipoprotein and ApoA.
ApoA.
Yeah, it's key protein in HDL, linked to heart health. This whole process is vital for reverse cholesterol transport, basically, pulling oxidized LDL off artery walls. Super important, transdermal estradiol, the patch or gel, it has much less effect on lipids. It's a key difference we should probably circle back to.
Definitely. Okay, now let's turn to something I think will surprise a lot of listeners. It certainly challenges some, deeply held beliefs. Breast cancer mortality. The sources had some really, frankly, astounding findings here. What did they reveal?
Yeah, this is where it gets really interesting, and it often flips conventional thinking right on its head. The medical literature, the science presented in these sources, it suggests that estrogen, specifically estradiol, is the only drug shown to result in a decrease in breast cancer mortality.
Decrease, not increase.
Decrease. One meta-analysis even showed slightly more breast cancer deaths in the group taking tamoxifen compared to a control group, while the estrogen group, they showed a significantly decreased risk of death from breast cancer.
That is completely counter to what most people hear.
Absolutely. And the sources point out that despite maybe 20 years of this kind of evidence, it's often ignored in practice. Oncologists often continue prescribing aromatase inhibitors. They work for about 5 years maybe, but then resistance can develop, hormones become independent, and recurrence happens. Also, long-term tamoxifen use can lead to resistance to estrogen's own apoptosis-inducing effects, basically. Cancer cells stop responding. High-dose estradiol has even been looked at as a potential alternative to chemo for certain patients whose breast cancer is resistant to AIs and tamoxifen.
An alternative to chemo based on estradiol.
In selected cases, yes. It's a remarkable potential reversal based on the evidence in these sources. Truly challenges the narrative.
It really, really does. Astounding. Okay, lastly, what about cognitive function and quality of life?
Well, the sources indicate that hormone replacement therapy, HRT, with estrogen can really help with those climacteric symptoms, hot flashes, night sweats, that kind of thing.
Yeah.
And maybe even more importantly, it might help prevent long-term issues like cognitive decline and Alzheimer's disease. So the benefits seem pretty wide-ranging: physical, mental, longevity.
Okay, so given this really broad, powerful range of benefits, the crucial question is how to best use it. You mentioned the oral versus transdermal difference. That's a common confusion point. What do the sources clarify there? It sounds nuanced.
It is nuanced, and yeah, the form of administration really matters. And those perceived risks, often misattributed. Let's start with oral estradiol. The big benefit, according to these sources, is its major effect on lipids and lipoproteins. That's what drives the improved cardiovascular protection, lowering LDL, raising HDL.
And that's because it goes through the liver first.
Exactly that, hepatic first-pass metabolism.
Yeah.
That's where it impacts the lipid profile so strongly. Studies using oral estradiol, like the CORE study, they didn't show an increased risk of heart disease, plaque rupture, or other adverse events compared to placebo.
Right. So if oral estradiol has these benefits and seems safe in those studies, why the persistent idea that oral estrogen causes blood clots? Where does that come from?
Excellent question, and the sources tackle this directly, that perception. It largely comes from older studies that used conjugated equine estrogen, that's Premarin, or studies where estrogen was combined with synthetic progestins like Provera, especially in older women, like in the big WHI and HERS trials.
So different drugs, different combinations.
Exactly. Oral estradiol itself is actually less likely to cause clots, less thrombogenic than Premarin. One expert in the sources put it pretty bluntly, something like, "Show me the study that oral estradiol causes blood clots." Well, it could, it might. If you say it could and it might, that means it doesn't. It highlights the lack of direct evidence for this specific form, oral estradiol, causing significant clot risk compared to placebo, unlike the synthetic progestins or the conjugated estrogens.
That clears up a lot. It suggests the risk was tied to the other components or types of estrogen used in those big, widely reported trials.
Okay, so what about transdermal estradiol then? Yeah. The patches, the gels.
Right, transdermal. Its big plus is safety regarding clots. It has basically no effect on clotting factors.
Right.
So it's considered very safe, a good option for women maybe with a history of blood clots. And it still gives you those important benefits for bones, brain, tissues, vaginal health.
But the limitation, compared to oral, is it has a much less significant effect on lowering lipids. And because of that, so far, studies using transdermal haven't really shown those same big cardiovascular disease outcome benefits, probably because it bypasses that first pass through the liver.
So it misses that lipid-modifying step.
Pretty much. For practical use, estradiol gel is usually well tolerated. Sometimes dose-related breast tenderness or postmenopausal bleeding can happen, and things like vaginal suppositories, 8.1 milligram, they can treat local symptoms effectively. Higher doses might need progesterone added though, so yeah, the form really matters. You have to weigh the goals and the individual's risks.
Understanding those differences is clearly key for personalized approaches. Okay, that brings us to our final piece, estradiol in perimenopause and long-term use. When to start, how long to stay on it? Big questions for many.
Definitely. Drawing from the evidence here, the main reason to start HRT is usually treating those climacteric symptoms, the hot flashes, sweats, etc., in younger perimenopausal women. So typically before age 60 and within about 10 years of menopause starting. That early start isn't just for symptom relief now, it's also linked to preventing those longer-term degenerative diseases we mentioned.
Okay, early start for symptoms and prevention. Any cautions for perimenopause specifically?
Yes, a critical one. Unopposed estradiol, meaning estradiol without progesterone alongside it, can cause the uterine lining, the endometrium, to thicken too much. That's called endometrial hyperplasia. So if you're using a form of estradiol that raises blood levels significantly, like maybe ephemering, you absolutely need progesterone opposition to protect the endometrium. Other local vaginal treatments, like estradiol for estrine creams, they usually don't raise blood levels enough to affect the uterus, so progesterone isn't typically needed with those.
That's important.
And also, during perimenopause, cycles can become anovulatory, no egg released. This is common, also seen in PCOS. It leads to progesterone deficiency. That deficiency itself raises the risk for endometrial cancer, so in those cases, continuous progesterone can actually be preventative.
Crucial distinctions there for perimenopausal women. Now, what about long-term use? We often hear lowest dose, shortest time, but the sources seem to push back on that.
They really do. Quite strongly, actually. The prevailing data in our sources suggests something more like hormone therapy should be started at menopause and continued indefinitely. That's the implication from studies like the Danish, Finnish, DOPS, and again, the estrogen loan arm of WHI. They support starting HRT in recently menopausal women and continuing long-term without seeing increased risks of major issues. It all comes back to that timing hypothesis. Start early, get benefits, start late, especially after 63. You might even see some paradoxical harm, particularly for heart events initially. So this directly challenges that common advice. Lowest dose for the shortest time and stop. Some experts in the sources flat out call that advice invalid.
Invalid, wow. And the fear driving that advice.
It seems largely driven by misinterpretations of those older WHI and HERS trials, particularly the negative effects that were actually linked to the synthetic progestins used in those trials, not necessarily the estradiol itself.
What an incredible deep dive into estradiol. Seriously, from its huge role in heart and bone health, those surprising findings on breast cancer mortality, and then the critical differences between oral and transdermal.
Wow. We've definitely uncovered a lot of nuance today. It really shows how vital it is to look past the headlines and, really dig into the evidence.
It really does, and this raises, I think, an important question for you, our listener. Given how often established guidelines or common practice seem to diverge from what a deep read of the scientific literature suggests, well, how much more do we all need to question and educate ourselves to really optimize our health?
A very thought-provoking question indeed.
And next week, just as a heads up, we'll continue exploring this critical life stage with a deep dive specifically on perimenopause, building on a lot of what we've touched on today.
Excellent. Looking forward to that.